I mentioned we do a lot of work for federal agencies. The primary federal agency that is engaged in rural health work is the Health Resources and Services Administration. That's one of the agencies within the Department of Health and Human Services. The Federal Office of Rural Health Policy is the subdivision of that agency where that rural work resides. This, just in terms of rural policy, this is an issue unto itself because the entire focus of our federal government on rural health is housed within one agency within the Department of Health and Human Services. And that happens to be the agency that is singularly concerned about healthcare access, which is an important issue. But it's not the only issue. Meanwhile, our National Public Health Agency, CDC, does not have its own Office of Rural Health. CMS, which pays for healthcare, does not have an Office of Rural Health. So we kind of have this very myopic, very narrow focus within the rural health community on access to care as though that's the only issue. And that's just kind of the problem in and of itself. Other agencies have started to get engaged a little bit. CDC is nibbling around the edges of rural health, and we're doing a little bit of work for CDC. We do work for USDA, I'll share some of that with you. And then the Appalachian Regional Commission itself is a federal agency. A lot of people don't realize it's a federal agency, but it is the federal agency that's exclusive focus is on economic development throughout the 420 county Appalachian region. And within that, they look at specific topic areas like health and education and others which influence economic development within rural communities. So that's a little bit about the Walsh Center. Broadly, NORC, I'll tell you again a little bit more because as Dr. Beatty mentioned, this is an opportunity for people who are getting their degrees in public health. We hire a lot of people straight out of undergraduate and graduate school as research assistants and analysts. It's a great introduction to health research and health policy. We work with federal agencies, so it's a nice way to connect in with what is happening in our federal government to influence the health and well-being of populations. There are a lot of organizations like us. Some are nonprofit, some are for-profit. It doesn't, nobody's going to judge you if you want to work for a for-profit organization. What I would tell you is you need to just go in with your eyes open because every organization's focus is a little bit different. We're all competing for the same work. It's interesting work by and large, but the motives are a little different. So in the for-profit sector, you have to answer to shareholders, and sometimes there are pressures to generate profit, which influence the work. In the nonprofit organizations, our costs are the same, our structures are the same, the pressures are the same, but at the end of the day, whatever profits we happen to make get reinvested back into our staff and into our function, into how we function. So personally, I'm a little biased towards the nonprofit side, but there are a lot of good organizations, and we're all competing for federal grant dollars. So something to keep in mind. So what I want to do is I want to highlight really 3 different project areas that we've been focused on that I think have really interesting health policy implications. The first is our work looking at health disparities within the Appalachian region. So this, and I'll tell you what we're looking at here. This is actually a project that we did actually for the Federal Office of Rural Health Policy, where we tried to create these dashboards to help people understand rural disparities within different regions of the country. So we did this for the Appalachian region, for the Delta region, and we did it for every one of the HHS regions. And basically what we have along the x-axis are the 10 leading causes of death, and then along the y-axis we have the rates indexed to 100, which is the average for each of the 10 leading causes. And then the colors are the different levels of geography, so rurality. So green is urban, and the oranges and yellows are rural by different rates of rurality. And what you see is that for lower respiratory disease, and this is for females, if you are a female in Appalachia, you are 2.6 times more likely to die from lower respiratory disease than women in the rest of the country. And you can see that these orange dots are almost always higher than the green dots, so that is the rural disparity. And you can see in the Appalachian region that almost everything is above the national average. So again, it's kind of a dashboard, a snapshot way to look at what do these disparities look like within our region. And then this is the same thing for males. And again, you see lower respiratory still much higher, not quite as high as for women, but still much higher. One other interesting thing that I always find fascinating in this is if you notice here, homicide, the rates for homicide tend to be higher in urban. That's the one area where the disparity is the opposite. But for men in rural areas, the homicide rate is around the national average. If you go back to women, the homicide rate is about 60% higher for rural women. So we get into issues around domestic violence, things like that. So there are, again, some really interesting implications as we look at these data and start to pull them out. This is data from 2011 to 2013. We are currently in the process of updating this, so we'll have some new charts soon, and we're going to be doing this actually for every state in the nation, which I'm really excited about. Because when we go and talk to people at the state level, saying what the HHS region rate is really doesn't have a lot of meaning for them. Health policy happens at the state and local level, so you need to get that data down to a more granular level where it's meaningful for people. So the other thing that we did recently, and this was a study we did initially with 2015 data, but we have since updated it for 2017. This was a project we did for the Appalachian Regional Commission where we looked at deaths of despair in the Appalachian region. How many of you have heard of deaths of despair, that terminology? So I'll give you a little bit of background on it. So there are a couple of researchers at Princeton University. They're actually health economists. It's actually a married couple, Angus Deaton and Ann Case, who came up with this idea of deaths of despair. What they were finding was that among working class Caucasian populations, the trends in mortality were really starting to go in the wrong direction, primarily due to three causes: suicide, overdose, and alcoholic-related liver disease. And so they termed those deaths of despair, and kind of built into that hypothesis is the idea that areas of the country that have struggled economically, like Central Appalachia, like some of our Rust Belt states like in Ohio and Michigan, in areas like that, because of that economic despair, people are turning towards drugs and alcohol and suicide. And so we thought, well, you know what? The population they're looking at actually is very much an Appalachian. Appalachia fits that demographic profile. Let's look at this within the Appalachian region. And what we found was that in Appalachia, overall, rates across these three causes of death were 45% higher than in the rest of the country. For overdose, rates were 65% higher in the rest of the country. Suicide 30% higher, and alcoholic-related liver disease 10% higher. So in fact, we did see these disparities across the region. One of the things, so we updated this to 2017 data. One of the things I will highlight in this, because I think it is notable, when we looked at this data initially for 2015, the numbers were lower, so these have continued to trend up, but in general, they've trended up in parallel with the rest of the country, so that between 2015 and 2017, the rate remained 65% higher. So again, they both trended up but parallel. Alcoholic-related liver disease went from 8% higher to 10% higher within the Appalachian region. But for suicide, within a 2-year period, the rates went from 20% higher to 30% higher. So that's a 50% increase relative to the rest of the nation in 2 years. And that's something I've been talking about a lot, even as we are all focused on overdose and opioids. We actually have a suicide crisis within the United States, a lot within rural areas in general, a lot within our Appalachian region, and we need to be thinking about what do we do to mitigate that and prevent that as well. So from there, what was interesting is that when we looked across the Appalachian region, Again, I mentioned this is the Appalachian region right here, as defined by the Appalachian Regional Commission. 420 counties going from the southern tier of New York all the way down into Mississippi and Alabama. It is a very diverse region, economically and demographically, even though we often think about Central Appalachia, which is a little bit more homogeneous. What was interesting in looking at this data was the differences in rates between Appalachian states. And essentially what we found was that, particularly for overdose, the highest rates were concentrated in Central Appalachia. You can see that really well here on this map that we developed. But the rates are actually really low in Southern Appalachia. And that's kind of intriguing. Does anyone have any thoughts on why that might be? What we think this is, and again, in terms of policy implications and prevention, I think this is notable. What we think this is, so Southern Appalachia, this is very much a rural African American population, and as we look at health disparities, when you overlay race and ethnicity with rurality, you see a lot of dual disparities, and I'll show you some of this later. So if I were to show you a map of where heart disease was highest, you would see it here, cancer here, really almost across the 10 leading causes of death, you would see it there, but somehow opioids overdose behaves differently, and what we think is happening is that this is a result of structural racism within the medical community, which actually had some unanticipated benefit, which is kind of a hard thing to get your head around. So doctors, there's a lot of study that doctors and health systems underprescribe medications to minority populations. That's often a bad thing, but guess what? When it's a highly addictive substance, it may have actually been a protective factor in Southern Appalachia. So again, kind of an unexpected impact, but something that really kind of jumped out at us with this data. So a few things that I started to try to conceptualize and think about, and I put them on this slide. As we think about overdose data, so essentially what this map is overdose mortality data. So this is essentially a heat map of the number of people who are dying from overdose. And we map the 10 leading causes of death because they kill people. So our best data to understand any health issue is mortality data, because it's a complete data set, because all of us at some point are going to be part of that data set. We all die at some point. Other types of data are not as good. So if we want to find out about health behaviors, smoking rates, if we want to find out about belief systems, we have to actually ask people. And we do that through surveys. And the sample sizes of those surveys are never large enough to get down to that community level. So we're not able to really map it. So we can tell you nationally that people in rural communities smoke more, but we can't really take that down to the granular level. With mortality data, we can, and that's why we like to use mortality data. But even then, overdose mortality nationally is estimated to be about 35% underreported. So as bad as all of this data looks, it's probably 35% worse, which is hard to get your head around. The reasons that it's underreported, anytime there is an issue that has stigma associated with it, especially in rural areas where people are more closely connected, it's just naturally less likely to be reported because they try to protect people's reputations. So suicide is underreported in rural areas, HIV is underreported in rural areas, and overdose is underreported in rural areas, along with a number of other things. Another factor is the data that I showed you is all-cause overdose data and not opioid overdose data, and this gets into the weeds a little bit, but the reason for that is that this is data, it's vital statistics data, this is data that is reported on a death certificate, and the people who are filling out death certificates are either coroners, medical examiners, or attending physicians, and they use ICD-10 codes, and when you select that ICD-10 code, the top code is overdose. And then if you want to say what kind of overdose, you have to go into a subcode. And a lot of attending physicians and medical examiners never bother to go to that next level. So the data gets less reliable the more specific you get. So we report all-cause overdose, and then nationally, it's estimated that about 68% of all-cause overdose is related to opioids at this point. I mentioned this already, but we count what kills. We don't have good data on other substance use disorders. So the one thing that we hear about all the time now, which is a critical issue, and I'm sure you guys hear about it as well, is methamphetamine. When we talk to people in communities, we are often going in with opioid data because that's the data we have, because it's more likely to kill people. But then we hear from them, you know what, we think our issue is actually methamphetamine, and it may be, there's just not as good a way to capture that because it tends not to be a cause of death. People with methamphetamine addiction tend not to die from that addiction, they die from other things. So we don't have a good sense for other substances. And then opioids themselves, and this is one of the things that really concerns me, and I think this has all kinds of policy implications moving forward, particularly as our federal government throws billions and billions of dollars to try to address the opioid crisis. When we're talking about opioids, we talk about them as though they're one thing. You know, opioids are a cause of death, but in fact, opioids are prescription drugs, and they're heroin, and they're synthetics, fentanyl, and each of those is different in the level of lethality. And I think this is actually a CDC chart, and I think it just shows it really well, where you see that they refer to the 3 waves of the opioid crisis, and you see that prescription drugs led to a lot of those overdoses early on, and then as states started to implement policies to clamp down on prescribing, you know, again, this is I think an unexpected policy impact. State legislators and governors were looking at this prescription drug crisis, and they said, well, the answer to this is to give people less access to prescription drugs. And on the one hand, that seems intuitively like that might be the case. But guess what? If you take away people's prescription drugs but never address their underlying addiction, they still need to feed that addiction. And they're going to find other ways to do that. So we move then from prescription drugs to heroin. You see heroin taking over. And then more recently, as fentanyl has been laced into the heroin and cut into heroin, you've really seen the number of overdose deaths spike. The implication of this is that if we get our heads, our arms around one of these types of substances, we may not have addressed the other. So my big concern in the opioid crisis right now is that if we see rates starting to go down, and in fact in a lot of places they are starting to go down, that may mean that we have gotten some of the synthetics out of the system, which is a great thing. We don't want people to die from these substances. It doesn't necessarily mean less people are using these substances. So we initially did our first study looking at overdose mortality back in 2008. And in 2008, we were able to document the opioid crisis, and it was this crisis right here. So this is 2008, and you see, we were documenting this prescription drug crisis. If we got all of this down to this level right now, people would think we've solved the problem, but we've just solved part of the problem. So again, you've kind of got to tease out what proportion is from each of these different substances, and if you address one without addressing the underlying addiction, you may not have solved the problem. The other thing that's complicating this now is that we've gotten really good at saving people's lives through Narcan and naloxone. These are substances that bring people out of that overdose. Well, if people don't die, we don't count them. So we don't know how many people are overdosing, we just know how many people are dying from overdose. So if we are getting really good at saving people's lives from overdosing, the overdose rate could go up, but the mortality rate could go down at the same time, and we may not know that because the thing we're counting is deaths. Does that make sense? Okay. All right. Anybody have any thoughts on any of that before I completely switch gears on you? switching gears a little bit, I told you I'm gonna give you 3 very different topics. So another area that we have focused on a lot is rural public health infrastructure and financing, and actually we've done a lot of this work with Dr. Beatty and colleagues here at EPSU. So this is something I just wanted to start off and show you. So how many of you have heard about the rural hospital closure crisis? Been in a lot of the media. I see some hands going up. And that is a problem. I don't want to take anything away from it. In rural communities, we need to have hospitals for economic viability and for health and well-being. There's a lot of important reasons to have rural hospitals in our communities. But because hospitals are accredited, we can tell you where every hospital is in the country. When one closes, we know about it. Nobody is counting health departments or public health agencies in the same way. So through the popular media, we have found all of these examples of health department closures and cutbacks. And this is all under the radar because it's not something that's tracked. This is another crisis that we need to be paying attention to. These are the people who are inspecting our restaurants, making sure we have clean air and water. We're doing the immunizations in our communities. We're providing a lot of critical public health services in our communities. And they are just as important to the health and well-being of our community. So when they go away, it puts our communities at risk. But when they go away, we simply may not be aware of that unless we happen to live in that community. We're trying to think about ways to track this a little bit better, in fact. So a little bit about how public health is funded. So health departments, local health departments are funded through a mix of local tax revenue, state dollars, a lot of federal dollars, and those federal dollars tend to flow through states, and then some clinical revenue. The vast majority of the dollars that fund your local health departments are actually federal dollars that have filtered through the states down to the local communities. And then in terms of where those dollars come from, one of the things that's very surprising to people, everyone thinks, well, naturally it should be coming from CDC, but the agency that is the largest funder of public health is actually the USDA, Department of Agriculture, and that's because they fund the WIC program and childhood nutrition programs, which are core programs within most health departments. So problems with the way that public health is funded. So you guys have probably heard this, but when public health is doing its job and nothing bad is happening, nobody knows public health exists. But when things go wrong, suddenly everybody's concerned about public health. So we tend to be funded crisis by crisis. So a few years ago, it was H1N1, pandemic flu. We got this huge bucket of money to prevent flu. Then came Ebola, a huge bucket of money to prevent Ebola. And then Zika, and now it's opioids. So we tend to kind of skate along from crisis to crisis instead of having stable funding to support basic public health services. That's a problem in this country. We just don't value public health in the same way that we value other core government services like police and fire and education and other things like that. Those federal dollars, when they do come through to health departments, they're coming through in categorical ways. All of this goes back to Congress. If you want to figure out who to blame Congress. So essentially you need to look at each federal appropriation, and you need to look at what is funded within that, and you will see that every program that CDC has, every program that USDA, any federal agency has, is written as a line item in the federal budget, and they come with a lot of requirements on how those dollars need to go. So all of that flows down, and those local health departments essentially are having to implement those federal programs, whether that's their local priority or not. So they have less flexibility than I think people would imagine. And then federal funding has actually decreased over time, which is a concern. And in addition, state and local dollars have not been going up. So we are actually seeing, that's why we're seeing those cutbacks in public health services, is that the funding just isn't there. So just to put this into a little bit of perspective, so this is basically the proportion of funding that's coming from different sources. This is urban health departments, large rural and small rural. And what you see here is urban health departments have a much higher proportion of their dollars that come from local tax revenue. That tends to be the dollars that are flexible. They can address local needs with those. Rural communities have less local dollars, less flexibility to address local needs. Conversely, this is the proportion that's coming from state and federal dollars. Those are the ones that they're being told what to do. It's categorical funding. So those rural local health departments are actually less flexible. They are more reliant on those dollars. And when there are state and federal budget cuts, it hurts those local health departments more, those rural local health departments. The reliance on categorical funding is the same thing. That categorical funding is not flexible. The more reliant you are on less flexible dollars, the less flexibility you have. And then health reform has been really, really interesting. So this is the Affordable Care Act. We actually did work for the Assistant Secretary for Policy and Evaluation within HHS to help them look at how the Affordable Care Act is playing out and whether it was impacting state and local health department functions. And in fact, what we found was that urban health departments I'll back up. So essentially what the Affordable Care Act did is it covered a lot of core services that were provided by local health departments. So you no longer had to go to a local health department for immunizations or breast and cervical cancer screening. A lot of things that CDC funded health departments to do are now covered benefits because you now presumably would have insurance through Obamacare, right? Whether it played out like that or not is a different story, but that was the vision. So if you're in an urban community and suddenly everyone has this new insurance card, they can vote with their feet. They don't have to go to the health department for those services. And if you're an urban health department, you can look at that and say, you know what, we can divest these services, and because we have a lot of local dollars, we can double down on doing population health work. And that's great for their communities. If you're in a rural community though, people can't vote with their feet because there's limited access to healthcare services. So it may be that they now have this insurance card, but if there are no new doctors in your community to serve that additional capacity, they need the health department more than ever to provide those services. And in fact, it may be a benefit to the health department because they can now be reimbursed for those services. So at the same time that we see urban health departments moving away from clinical services, we saw rural health departments expanding clinical services. It's actually really fascinating, and the policy question here is, what does it mean when our health departments in the nation are headed in two different directions based on the geography they serve? And I don't have an answer to that, but I think it's a really important question. If you are the national association that represents those local health departments, called the National Association of County and City Health Officials, if you're that association, you've got to figure out how do we serve our members who are now diverging in the types of services they provide. Really interesting implications for this. All right, I'm going to switch gears one more time, and I'm going to tell you about our latest project, which you have not seen yet. It's something I'm really excited about. So we've been doing a lot of work for the USDA. So this is not our work. This is actually, I think, a really interesting background piece. And this actually is data from the USDA, but it's not our data. This is from the Economic Research Service. And so this, I think, is just really fascinating. It tells that rural story that underlies so many of the health inequities that we see. But if you look at these lines, so this is job growth. That's what the orange and the blue line are. So the blue line is urban job growth, the orange line is rural job growth. And what you see is that, of course, job growth went down during the economic recession, as you'd expect. But from 2007 on up to 2009, they were really close. Urban and rural job growth really moved in parallel, and they were very, very similar. But since the end of that economic recession, look at what's happened. Urban job growth has really eclipsed rural job growth. The opportunities have not grown in our rural communities in the same way. And that, I think, underlies a lot of the challenges that we see. So what are we doing right now? So this is the project we're doing for USDA. We've been charged with creating a prosperity index. So USDA, Department of Agriculture, is the only federal agency that is exclusively focused on rural populations. They're not focused on health, but on rural populations because it's agriculture. And we're doing this work for USDA's Office of Rural Development. So this is the economic development engine within USDA. And what we did is we convened an expert panel of people to help us think through what are the measures or indicators of prosperity within our rural communities. And we created this 2x2 matrix. So we wanted to think about factors that were tied to risk and resilience within communities, positive and negative. And we wanted to think about economic issues and social issues. And we wanted this to be balanced. So we came up with 4 key indicators in each cell. And we wanted these to be things that at the community level could theoretically be changed so that in providing this kind of information to a community, if we tell them how they score in each of these indicators, we can help guide them to think about ways to increase resilience within their community and decrease risk. So that's the vision. And these are the indicators that we ultimately came up with. So it includes poverty rate, industry dependence, so how diverse are the industries within your community, negative net migration, and then labor force participation. Economic resilience, we looked at the percentage of people who are self-employed or own their own businesses, the number of employers per capita, again, diversity of that workforce, the number of hospital beds per capita, and median household income. On the social side, we looked at digital distress, high school dropout rates, teen birth rates, and all-cause mortality. And then in terms of social resilience, we looked at the number of nonprofit organizations per capita, percent of people with a college education or higher, access to healthcare, and that's essentially the number of primary care providers per capita, and then voter turnout, which is a great indicator for social connectedness. And so, in addition to providing the national data, this is what we're providing to every community. So we're basically going to create a national map where in your county you can pull down the data specifically to your county. You can find out how you score to your state, to the national average. You can think about ways to increase that economic prosperity within your community along these dimensions. So this is where it gets interesting. So this is how it all maps out. So if we plot economic prosperity based on those 16 measures that I just showed you, this is the map that you get. So what do you notice about this map? I'm going to show you some other maps too to compare it to. What regions do you see?
The southeast, and it looks like a lot of reservations here in Fort Lee.
Good eyes, yeah. The reservations, a lot of people miss the reservations. Absolutely the southeast, central Appalachia. This is the Delta region, and then the US-Mexico border region, and again, the Native American reservations. The other thing that's interesting here are those, what I would call the at-risk communities, those communities in yellow. This is that Rust Belt, those post-manufacturing regions of our country. They don't like being called Rust Belt. That's not a positive frame. But these are the places where there's been a lot of manufacturing, and that has essentially moved offshore. So I'm going to show you a couple of other maps, which I think are really interesting comparisons. So this is a map of persistent poverty in the United States. So to be defined as a persistent poverty county, you have to have 20% or greater of your population living below the federal poverty level since 1980, since the 1980 census, okay? So this is 40-some years, 50 years of intergenerational poverty. And you see the same regions, right? So in some ways, this kind of validates our prosperity index. We were able to pretty accurately, based on those 16 indicators, show you where there are deep levels of poverty in the country. And that to us is validating. We want to go one step further. I mean, we could have just pulled up this map if that was our end goal. We didn't need to create a new one. But again, providing the underlying reasons for why people are scoring where they are, again, hopefully helps provide a path forward. So this is where there are rural African American populations living in our country. And what do you notice? It's the rural South and the Delta. And then this is where rural Hispanics live in our country. And you've got the US-Mexico border region. So this interplay between race and ethnicity and geography does lead to the outcomes that we see. And again, if I were to show you, with the exception of overdose, if I were to show you health outcomes on almost any of the 10 leading causes of death, it would really follow these same patterns, which I think is really notable. And then this is where Native Americans live in our country. Just, again, those same reservations where we see that persistent poverty. And then, as I mentioned, this is the work that we did. So this is the national map of opioid overdose. It behaves differently. So again, those persistent poverty counties tend to be places where there is the overlay of race and ethnicity with geography, and Central Appalachia, which tends to be Caucasian and poverty. So that's unique in that. But when we look at overdose, what we see is Central Appalachia, the Northeast, which is relatively prosperous, and then parts of the Southwest. And again, it brings into question what are the outside influences that essentially were stronger than the predictors of poverty that are also contributing to the opioid crisis, to the overdose crisis. So I think there's some really interesting factors at play. I think the greatest is how drugs are marketed and outside influence of the pharmaceutical companies and pushing those drugs in certain regions of the country. But there may be other reasons as well. And then this is something new. I'm really excited about this also, because this is what gives me hope, because I know I've just depressed you a lot, right? So this is what gives me hope. So what you were seeing here are the places in Central Appalachia. So these are all states that go into Central Appalachia. And what you're seeing here is the relative change in overdose mortality between the two 5-year time periods we've looked at. So it's 2007 to 2011 compared to 2012 to 2016. So we've aggregated data across two 5-year time periods. The dark orange are the places where opioid overdose has gone up dramatically. And guess what? We've got some dark green, which means that opioid overdose has gone down dramatically in those places over those two 5-year time periods. And this is exciting to us because the overall opioid overdose rate is still super high in Eastern Kentucky. So if you were to talk to people in Eastern Kentucky, they would not be telling you that they're actually having their overdose rates going down, because when you're drowning, it doesn't matter whether you're 1 foot underwater or 10 foot underwater, you're still drowning. So they haven't gotten to the point where they're seeing that success. But we have evidence of success, of people working in communities and making a difference. And we're just beginning a body of work now, and I'm actually going to be spending next week in Eastern Kentucky, where we're going to be doing a type of research. It's called positive deviance research, where we're going to be trying to explore what is happening in these places that are causing things to diverge, causing rates to improve even in places that are similar demographically. And what's really unique and interesting about this right here is the West Virginia border. So you see all this green here, just look right across the border in West Virginia. Whether you live on one side of the state line or the other is kind of arbitrary and should not determine whether you're going to die from overdose. But there is something different happening in Kentucky, which is encouraging. We're also seeing that trend play out a little bit in Virginia, and we're starting to talk to some people in Virginia about this as well. But I think hopefully we're onto something. Now, what I will tell you is just because things are getting better doesn't necessarily mean it's for a good reason. So, our hypothesis is that there are policies and interventions that are being implemented in Kentucky that are making a difference. But we may find that there's something else going on. So, for example, when I share this data with people, the very first thing a lot of people say is, everyone who is addicted to drugs has died, so the rates are going down, right? We could find that. We could just find that it's kind of the natural cycle of addiction, and that the people who are addicted to these substances have come in contact with fentanyl and suddenly they're all dead and the rates go down. I would think, though, that West Virginia would be going down too if that were the case. So I'm still optimistic, but you got to do the research to find out what the rationale is. Does anyone have any thoughts on why they might be going down? I love ideas. So our meetings in Kentucky, we're going to be meeting with stakeholders throughout the state, and essentially what we are doing is generating hypotheses at this meeting. We're going to be going and meeting with people and saying, here's the data, why do you think this is happening? We're going to use that to generate hypotheses, and then we are going to go back in a couple of months with a robust set of interview protocols, meet with the key players who are behind those policies and interventions, and trying to tease out exactly what the reason is behind it. So just to put a little bit more on this, these Eastern Kentucky counties, so these 5 counties, we looked at every one of the 3,000 and plus counties in the United States, and we ranked them by the rise or decline in opioid overdose rates. And 5 of the 10 top counties with decreasing overdose rates in the entire nation are clustered together in Eastern Kentucky. So that's pretty remarkable. Again, gives me reason for it. And that's all I got for you. So if you're interested in any of our resources or tools, this is where you can find our information. We always love to have people follow us on Twitter. And you can always find any new updates about what we're doing on our website.
Thank you. Questions?
So I know that you do a lot of research in Appalachia, and you sound like you're not from Appalachia. So how do you personally connect to people in Appalachia and kind of create a repertoire with them to
That's
get
a great question.
accurate results, essentially?
Yeah, that's a really great question. So 2 things is, I'm from Northern Appalachia.
Sorry,
Which does not
again,
sound
Central
like Central
Appalachia,
Appalachia.
you
No, it's a good point. No, it's a really good question. More important than that, though. So part of the answer is, I can say that I have spent a lot of time in Appalachia. I have lived in Appalachia, even though it's Northern Appalachia. That helps get a foot in the door, but at the end of the day, I'm coming to you from Washington, D.C., and that automatically gives me 0 credibility. So your point is 100% spot on. The only way, and this is true in Appalachia, this is true wherever we do our research. We work all over the nation. I mean, I work with tribal nations up in the Dakotas. I work with people in Alaska. Wherever we go, we have to have partners who work with us in those regions, who are credible within those regions, and who can share their credibility back to us. They're the ones who give us credibility. So that work I told you that we're doing in Eastern Kentucky, we are not doing that alone. We are doing that with the Center for Excellence in Rural Health, which is at the University of Kentucky in Hazard. When we do work here, we are always working with ETSU. One of the things that I love, it's one of my favorite parts of my job, is I get to get outside of Washington, D.C. I have phenomenal partners, and my co-director, the same thing. She's actually from North Dakota. We have phenomenal partners all over the country who we can call up, who we can partner with to do that work, because we can't go in and say, we're coming to you from Washington, D.C. and you're here to help, because that does not help you work it.
Other questions?
Have you had, kind of relating to her question, have you had pushback from Native American tribes or anything? Have they? How
so-
hard has it been, and which areas has it been
Yeah.
harder with as far as Native American tribes?
So the work with tribal populations, it's actually the most gratifying work I do, because we put the time in to build the relationships. I'll give you a story, which is, it's one of my favorite stories, because it was kind of my introduction to how you do this work. So it's the same thing, you need tribal partners. So when we initially started doing tribal work, we worked with the National Indian Health Board, the National Conference on American Indians. You gotta have people who can help provide that credibility. But at the end of the day, we're evaluating a federal grant program, which is funding tribes. So we're kind of going in there almost as feds to work with tribes, and that does not give you a lot of credibility. So they are grantees, so they're obligated to work with us. That doesn't necessarily mean they're gonna do it happily. What we did is, for the first 2 years of this project, I've been doing it for 10 years now. The first 2 years, we built partnerships with the tribes we were working with. When we designed our evaluation, we designed it collaboratively. There's community-based participatory research. They were involved in the evaluation design, they signed off on it. When we collect data, we recognize that it is their people, it is their data. We are just using their data to do the evaluation, but they ultimately own the data. And we spent a lot of time going before tribal elders and tribal councils in order to get the approvals to do that work. So my favorite story, one of the tribes that we've worked with on this project, it's called Three Affiliated Tribes. It is the Mandan, Hidatsu, and Arikara tribes, who all merged together. And we went before their tribal council to get approval to do this research. That meant flying in to Bismarck, North Dakota, renting a car in January, and driving from Bismarck up and over about 3 hours to get to Newtown, North Dakota. And I get in there, and it happens to be a tribe where they discovered oil underneath the land. So every oil executive from Texas and me were there trying to get approval from the tribes to do things. It's kind of bizarre. We get there, and they don't have a quorum, so we're all sitting outside of the tribal conference room. Around 11 a.m., somebody comes out and they said, "We're one short of a quorum. If he doesn't show up in the next half hour, we're just gonna scrap this meeting and invite you back next month." And I'm, please show up. He shows up, and we all get in the room, so we got lucky he showed up, and the tribal chair gets up and says, "So we're gonna do this like we do every month. We're just gonna go in order on the agenda. We'll go till 2 a.m., we'll see how much we get through. If we don't get to you, we'll invite you back next month." And so it's, you gotta go through that process. Now, I was really lucky because the person I was working with was a former tribal chair of a different tribe. And as nervous as I was when I heard that, he said, "And as a courtesy to my peer, I'm gonna let them go first." So I was in and out. I got really lucky. I won the lottery that day. But you've gotta go through that process. So the flip side of that is our federal partner, 2 years in, we don't have all the tribal approvals. They were losing patience. And I actually had a federal agency say to me, "You need to go to them and you need to tell them that you are an agent of the federal government and they have to do this." I'm not gonna do that with a tribe and live through it. So yeah, you put in that legwork on the front end, and there are benefits on the back end. And now we have phenomenal relationships with all the tribes we work with. It's not just built on that front end work, it's built off of the work that we've produced over the years, and they're being able to see that we're advocating on their behalf. We are presenting their data about their people in a positive light. Whenever we write a report, they review it before it goes public, so it's all things like that. But it's a lot of work, but gratifying when you get there.
Yeah, talking about the data, so how do you, the communication with the regulatory bodies, the Congress, how do you go about that, and how do they see it? Any maybe, issues coming up, trying to work on the data or sort of thing?
Yeah, so that's a tough issue. So the work we're doing is on behalf of the federal agencies. Whether and how that data filters back to Congress is anybody's guess. I think often it doesn't, and that's a problem. So when you do work for the federal government, if your work is federally funded, you are prohibited by law from doing any sort of lobbying or advocacy. So you have to keep those things separate. So even if we've collected this great data, we can't go back to Congress directly to say, you need to do this, here's what the data says. So it has to filter through outside advocacy organizations to actually get back. It doesn't make a lot of sense. There is nuance to that. So what you will hear people talk about is instead of doing advocacy, they're doing education. So, they will go meet with members of Congress to provide education. And you can do that. You can share the data with them as long as you're not telling them what it means or what they should do with it. But there's a fine line there, and we try to keep those things as separate as we can. So there are organizations. So one in particular is the National Rural Health Association. They are a very robust advocacy organization. We can get data to them, and they can use it for advocacy where we can't. But at the end of the day, I worry that our members of Congress are not, frankly, all that educated about issues that they are responsible for making policy on. And that's not a knock on them necessarily. I mean, they're lay people who were elected to federal office. They need education, and we need to find ways to get that information to them so they can make informed decisions. Whether they do or not is anybody's guess after they get the information. So here's probably the dirty little secret about Washington, D.C. All of your elected officials, they are less important than their staff. So Washington, D.C. is run by really, really unbelievably smart people between 20 and 25 years old who do all of the work. They do all the background research, and they're the ones who are informing their bosses on the policies they should be implementing. So at the end of the day, it's more important to get to the staffers than the members themselves.
One other question.
Mhm.
I was curious about the data that you need. Isn't there a way to lay the groundwork for better data? Like requesting medical facilities use that drop-down menu and specify?
Yeah. It's a good point. It really is. So there are a lot of conversations around this, and one of the challenges is that we don't have a public health system. We have 50 public health systems in the country. Everything is devolved down to the state level and even down to the local level in many cases. And the consistency across those states is very poor. So when we developed our mapping tools, we basically relied on the uniform data set that was out there, which is mortality data. And that could be collected a lot better than it is. We've been talking to CDC about that. But we know that there are states that are doing really good prescriptions on monitoring programs, really good data around hospital utilization and emergency room data. There is good data out there, it's just not consistently collected across states, so you can't compare across states. And that's a big problem. Figuring out how we create that consistency, I think, is probably one of the biggest steps forward we can make in the data that we collect. But that uniformity just isn't there.
There's gotta be some data on the amount of Narcan that
There
the
is.
first responders going through each
Yep.
little.
There is, but there's nobody who is aggregating that up. And even that data itself is probably not collected consistently across jurisdictions. Yeah, those are all the data sets we would love. I mean, we've got a wish list on data sets. So one of the things we're starting to talk about is, we have this nifty national tool that we developed for USDA. We want to start working with individual states to do what we're going to call enhanced tools, so that we can say to each state, what are the data that you're collecting within your state consistently, and we can create a state version that can be a much more robust version of this for you to inform your state level decision making, even if we can't roll that up to a national level. And that needs to happen.
that Narcan piece is really interesting. It's something that the state of Tennessee is interested in doing, so they've asked the center here to do some work around mapping that. But those EMS are at localities that are even smaller than counties, so it's a lot of different people collecting different data, so I mean, that's a really important thing for hotspotting where the issues are, because where you're dispensing that tells you where people are using, right? So, data is one of the biggest challenges we have in public health. It is old by the time we get it.
Well, and that's a great point. So the data I shared with you, mortality data, is 2 years old by the time you get it. So in December of each year, the mortality data comes out from 2 years prior. So next month, I will be able to tell you what the overdose issue looked like for 2018. So that's the other thing, is that these issues that change really rapidly, I'm not telling you the data for the current crisis, I'm telling you the data for the crisis 2 years ago. And that's scary, and it shouldn't be.
And that's the best data we have, because it's death, because that's the easiest one to
Right.
count. That's
So
the issue.
CDC does have a project, not every state is participating. It's called the ESOS project, ESOOS. It's Enhanced Surveillance for Opioid Overdose System, something like that. And it's basically a system where they are able to report the data quarterly instead of a 2-year lag, and that is absolutely huge. The actual reporting piece, it's a lot more complex than it seems like it should be up front. When those death records come in, they're reported to the state health department. The state health department needs to go through a big verification process. They need to roll it up, it needs to go to CDC. CDC needs to then verify it and clean it across states. That's why it takes 2 years. So essentially what they're doing is on a quarterly basis, they're reporting they're analyzing the data from the prior quarter so that it's always a team rolling to be able to do this in a faster way just for overdose stuff. The other thing is most of our data is actually survey data, and that's just unfortunate and scary, but it is what it is. And that's how we find out about health behaviors. So the Behavioral Risk Factor Surveillance Survey, the Youth Risk Behavior Survey, all of these are the National Survey on Drug Use and Health. It's phone surveys asking people questions about their health behaviors. And we do a lot of those surveys ourselves at NORC, and they're phenomenal. I'm blown away by the fact that they can talk to 2,000 people and they know how that rolls up to the national. They can actually tell you very precisely what the national rates look like by talking to 2,000 people around the country. That's great, but you can't say about any community because you would need 2,000 people per community to be able to do that, and nobody has the money to survey that many people. So the survey data is a big problem. In urban areas, often you do have a large enough sample that you can look at the behavior rates within an urban area, but to do that in rural areas is just impossible based on survey data.
So I have a question. What do you think are some of the policy things that are happening in Kentucky? Because you've been visiting Kentucky. I know the dean has been there a couple times. Because I'm wondering about this Narcan issue, or not issue, these interventions around Narcan. Are we just getting better at keeping people from dying in those areas?
So next week we're gonna generate some of these hypotheses. What I can tell you, and this isn't a specific answer, but I want to believe that this is behind it. So I mentioned we did that study in 2008. That was for the entire Appalachian region, and we documented the prescription drug crisis. When we released that study, the only Appalachian state, there are 13 of them, the only one that really cared about the findings from that study was Kentucky. And the governor of Kentucky at that time went on a road tour with us throughout Kentucky, sharing those findings, trying to get local stakeholder groups engaged. I think Kentucky actually had leadership back in 2008 to start addressing this crisis early, and I just think they're probably a few years ahead of every other state. What we're told is that rates are starting to go down in other places, but remember, the data that I'm sharing with you is 2-year-old data. CDC tells us that with the most recent data, they're starting to see some of those declines in other places, which is encouraging. I think Kentucky may be ahead of the curve because they started to address it earlier. One of the things I have heard, I've talked to some of the people who lead the treatment programs in Kentucky, and they talk about how they do not do treatment without jobs programs integrated into their treatment, because unless you give people something meaningful to do after they leave treatment, they're gonna fall right back into addiction. So giving them a way to get out and be productive is really important, and they think that that's a key. I don't know whether other states are using that model or not, but that's part of what we're gonna find out. And actually, we're talking to this Wednesday, tomorrow. We're talking to some researchers at the National Network for Public Health Law. They've done analyses across the 50 states looking at opioid laws. And we're gonna ask them that question too. I mean, people who are studying the laws and policies, are you seeing something different in Kentucky as compared to what every other state's doing that might be behind this as well?
Alright, my last question that they're gonna not be, I don't know if they're even thinking this, but what do you look for? So you said you hire a lot, and I work with tons of awesome research associates and analysts at NORC that Mike and his colleagues have hired. So what do you look for?
So the single most important thing we look for when you're hiring somebody is writing skills. And that may not be top of your mind, but what you have to remember is that as a grant-funded organization, everything we do comes from our response to a request for proposal. So we have to write a really compelling proposal, and we need people who can step in and help us write that proposal. And then on the back end, once we're done with all the research, it comes out as a project report, and that needs to be well written and succinct and compelling, just like the proposal does on the front end. So front end and back end is all about writing. We like people who have really good analytics skills, quantitative and qualitative. The research skill set is important as well, but at the end of the day, the singular thing that is most important to us is writing skills.
Any follow-up questions? I have one more. So the way you guys work is people get put on projects, so can you talk a little bit about time management and project management that you guys do?
It's tough. It's actually, I don't have a good answer. So we overwhelm our staff sometimes. It's a dynamic place. So essentially, most of our projects are $200,000 to $300,000 projects, and we have 3 or 4 people putting 20% of their time on each project. And that's kind of how we pull it together. What that means is on the other side, every person is working on probably 5 or 6 projects at the same time. And that's really good and exciting. People are exposed to a lot of different things. The work is generally interesting. People like that, but you can't control the clients and what they want in a manageable way across the time frame. So every now and then, everything hits at once. And we happen to be responding to an RFP at the same time. And so, suddenly everyone's overwhelmed and working 60-hour weeks, and then it suddenly goes away, and then there's a lull, and we're trying to figure out what we do. So just managing that and trying to maintain that balance is not easy, just because of the nature of how the work comes in and the work that we do. But at the end of the day, for us, we want our staff to be happy, we rely on them. But we also want our clients to be happy, because without them, we don't have jobs. So I always tell our staff, when they get frustrated, I always look at them and I say, well, do you know the golden rule? And generally they look at me very confused. And I'm like, well, it's not the one you're thinking of. the person with the gold makes the rules. And that's, you know, how we have to treat our clients. They're paying our salaries. They need to be the ones who are happy with everything that's produced, or we're not gonna have another chance. So it's really important. We have a phenomenal staff. It's a young and diverse staff from all over the country who are coming to Washington to be exposed to health policy. And they work hard and they're fun to be around. It's a great environment. We're all in it together. In the times when it's overwhelming, we're all overwhelmed together. But you know, we get through it together too. So it's I'm proud of all of them, and I think our work at the end of the day ends up speaking for itself. And then from there, you know, I will also tell you from there, you know, our staff, we love when they stick with us forever, but at the end of the day, I tell my colleagues who are my age that they need to be nice to all the staff who work for them, because 10 years from now, the shoe's gonna be on the other foot and we're gonna be working for them. They're all super smart and they're not gonna be our staff forever. They're gonna be moving on to bigger and better things, and they're gonna be the next leaders within the federal government and our state governments, and they're gonna be our clients. I actually have, you know, I've got a couple of my former staff now who I am now their client, so I am working for them. So it does happen, so you always gotta be nice to everybody.
How large is your organization? How many employees are there?
Yeah, so I'll give you the overall numbers and then break it down a little, because it's bigger than it seems. Well, it's not, it's big. So we've got about 2,000 staff. Most of them are in Chicago, where we have our big survey operations. To run survey teams is a huge labor force. In our Bethesda office, where we do the analytic research, we've got about 200 people. And then our Rural Health Research Center, at any given time, is probably about 15 people. And we kind of expand and contract as needed. So the neat thing about NORC and organizations like us is, as we bring in new work, we can pull from any of those 200 people and bring them into our project. So if we've got a new rural project, it's not like they need to go out and hire for the new rural project. We usually can pull some of our existing staff in, and then they can go on and work on other people's projects. But we have some core staff who we're always trying to keep on a little bit of, because we always want the people we like are the ones we want to control their time.
Yeah, which makes it hard for academia to compete, because we compete with Mike and his colleagues quite a bit across different different nonprofit and profit research firms, because they can surge capacity like nobody's business. We have to like go to HR, say we have this money, write a job description, get it classified, get it approved, and then like 6 months later, the person is hired. So we have to do some temp work, and they can just seamlessly start working on projects.
We can just jump in and get things done. The flip side, where
Very frustrating on
well,
our end.
but it's, frustrations go both ways. I mean, where we get frustrated is we don't have graduate students. We don't have a cheap labor force. So our costs are more expensive. So if we're competing on dollars, we're gonna lose. If we're competing on efficiency, we may win. So it depends on the client sometimes too.
It's
And
even
when we
worse,
partner, you get the best of both worlds. Yes.
it's even worse because my dad's retired, but he has specific capabilities. And there's a company out in California that he did some independent contract work for. They still use his resume periodically. They'll drop him a note and go, can we put you on this?
Yeah,
So they are strong in their resources.
they are. But that's a nice thing. We've had a really successful relationship with NORC because to the question about being legitimacy, like we are situated in Appalachia. We have a very strong community base of partners. So they can borrow from us on grants, we borrow from them, so we write each other in on a lot of grants, and that's a very fruitful relationship.
And one of the things that it's another one of those reasons I really like what I do. I think, and I attribute this to our being a nonprofit, I think we partner with other institutions much better than a lot of our for-profit counterparts, because nobody's putting pressure on us to hold every dollar for ourselves. We're very pragmatic. If, one, we like partnering, there's a lot of expertise out in the communities. People help us get into communities. There's all kinds of great reasons for partnering. But at the end of the day, the work is better, the products are better. It's more fun for us to be working with colleagues around the country to do this work. But we have that flexibility where I think some of our counterparts and for-profits just don't. And I think that is one of our competitive advantages.
All right, well, thank you, Mike.
My pleasure. Yep.
Mike will be up here and you guys can ask him the questions you were maybe nervous to ask the other one. He's very modest. The reason he can do all the work he does is he's a national expert. He's a keynote speaker at a lot of things. So we're very excited that he was able to come in to our class.